Thank you for joining this first of a series of PCR on call interactive live case discussions. Our objective by reviewing a single case is to discuss and understand the complexities of dealing with cardiovascular care and global care in the environment of the COVID pandemic. I'm welcoming Dr. Elad Maor, our friend from Tel Aviv, Sheba Medical Center, who will present the case, and Professor Flavio Ribichini from the University of Verona in Italy. Before handing the floor over to them, let me tell you in a few words the schedule of our discussion. Obviously, Elad will start by describing his patient. Then we will discuss the initial diagnosis and workup. After that, we'll go through the treatment and outcomes of the patient. And then will be the time in 30 minutes or so from now to open the floor to your questions or comments. So let's start by reviewing the case, and Elad, I'm handing it over to you.
Thank you, William. Welcome, everybody. So I will be starting by presenting a case of a COVID-positive patient with a chronic hypertension, scleroderma, and acute dizziness during their hospital stay. So let's start with the background and the history of present illness. We are discussing a case of a very pleasant 50-year-old female. She's a bank, she works at a bank employee, and she has a past medical history that is significant for scleroderma under methotrexate therapy. So she is immunosuppressed. She also has a history of a very well-controlled hypertension, treated chronically with ACE inhibitors and thiazides. Unfortunately, she and 3 of her coworkers contracted the disease at work. When she was tested positive, there was a discussion, should she stay at home isolation or should she be admitted, because she was asymptomatic, she didn't have any upper respiratory tract symptoms, and she was afebrile. But due to her immunosuppression state, the infectious disease team decided that it would be better for her to be admitted. So she was admitted to the COVID unit at the Sheba Medical Center. She was asymptomatic on admission, but as you can see, during her first day in the hospital, she started complaining of dizziness. Her vital signs show hypertension with systolic blood pressure of 87, diastolic blood pressure of 50. She was tachycardic at 100 beats per minute. She was afebrile, her body temperature was normal, saturation were normal, but she had a markedly abnormal ECG with what we will see shortly. It looked like an inferior STEMI, but she complained of no chest pain. She responded very well to intravenous fluids, and lab tests demonstrated elevated troponin at 19,000, where the upper limit of normal at our institution for women is less than 20. I should add that her D-dimers and also her C-reactive protein were borderline normal. So in the next slide, you can appreciate her ECG. I will give you a few seconds to look at the ECG. You can see her ventricular rate at around 100 beats per minute. You can appreciate ST elevation. The axis was normal, but you can see ST elevation at 2, L3, AVF, and also lateral leads at V5, V6, and L1. You can also appreciate some PR depression and reciprocal changes with what look like ST depression at V1, V2, and AVR. Also interesting to look is the poor progression of R waves in the anterior lead, specifically in V2, 3, and 4. Chest X-ray, You can see that her chest X-ray was interpreted as normal. There is no evidence of congestion, no evidence of pneumonia, or no other finding that might explain hypertension. Our radiology team interpreted the chest X-ray as normal. She was in a COVID unit outside of our heart institute, and over there, the internal medicine team performed a point-of-care ultrasound, and that ultrasound showed reduced left ventricular ejection fraction. And I'll show it again. It will run in a second here. Here you go. You can see what seems to be globally reduced LV function with maybe slightly more inferior akinesis or dyskinesis, and the patient had no angina, and she had normal O2 saturation. This point-of-care ultrasound was reviewed by our echo team, and our echo team was under the impression that maybe there was more inferior motion abnormality compared with the rest of the left ventricular segments. So then comes the point, how would you, in your institution, proceed? I will summarize. We have a 50-year-old female. She is an inpatient with COVID positive, with normal chest X-ray. She has no fever. She doesn't have any chest pain, but she does have an acute event of dizziness and hypertension. Her point-of-care ultrasound demonstrates a globally reduced left ventricular ejection fraction with possible inferior wall motion abnormality. ECG is suspected of inferior ST elevation. And as I showed you before, she has a markedly elevated high sensitivity troponin of more than 10,000 when the reference of upper limit of normal is less than 20. C-reactive protein is not elevated significantly. And also her D-dimer is borderline normal.
Thank you, Elad. So before we move to the discussion of the different options, perhaps you can clarify for us the strategy in terms of patient disposal. So this is a COVID plus patient, but she was not admitted in the cardiovascular division, was she?
That is true, William. She was admitted to the COVID unit, which is basically an internal medicine service for patients that are stable. She was stable, and the only reason for her admission was the fact that she was on chronic methotrexate immunosuppressive therapy. And then comes the question, if her main symptoms or main problem is hemodynamic instability and globally reduced left ventricular ejection fraction, should we transfer her to the heart center, or should we allow the internal medicine team to take care of her, with us cardiologists being only consulting as necessary?
Mm-hmm. Flavio, is that also your strategy? I mean, how to deal with patients that are COVID plus and prevent them from actually contaminating other people or the staff in the where they are admitted?
Yes, William, it's the same thing. Known COVID patients stay on a specific pathway and should not be mixed with COVID negative patients. So if she is admitted to the cath lab, which is a COVID-free area for an angiography or for an intervention, afterwards she will be sent back to a COVID intensive unit. When the patient is known to be COVID-free, then is admitted to the normal ward or the intensive care in the cardiology division.
Great. So maybe we can move to the next slide that shows different options in terms of management. And maybe I can ask you, Flavio, you mentioned invasive procedure. What would be your favored or preferred treatment option or further diagnostic workup in this particular patient?
Well, what is certain in this case is that the patient has a myocardial damage. She has an abnormal ACG, which is suggestive for ischemia, but can be also pericarditis or myocarditis. There is hypotension, so this heart is not working properly and is responsive to volume overload, so there is some hemodynamic problem. And there is an elevation, which is significant, elevation of troponin. So there is myocardial damage. At this point, the question is whether this damage is ischemic. So we will try to put the patient on our road towards the intervention and the cath lab, or it's not ischemic. And so at this point, I think that the echocardiography is at the crossroads. We have seen already a very, let's say, approximative imaging of the LV, which is certainly not normal. There is a diffuse hypokinesia. There is probably a segment of the inferior wall which is impaired, which corresponds to this ST segment elevation. So the suspicious of an ischemic event, I think it's well taken. But there are also other aspects of the ACG and the clinical history of the patient that may put the diagnosis apart from the need of an immediate invasive approach, which would be a watchful waiting for the hemodynamic conditions, being ready to support her hemodynamically if she worsens.
Mm-hmm. Yeah, actually, one of the colleagues watching the clinical history on the website yesterday, Dr. Said Sabek, he raised the hypothesis that perhaps this could be only myocarditis or pericarditis and not an inferior myocardial infarction. Although to me, I have to say that the ECG changes look pretty much localized to the inferior wall, compatible with circumflex or dominant right coronary artery ischemia, and also the hypotension I thought would fit in, for instance, right ventricular damage as an hypothesis. So maybe what are the different options, Elad, that your team considered in terms of differential diagnosis here?
I think that our team discussion was very similar to what Flavio just described. With the two possible working diagnoses were either a myocardial injury due to inflammation and viral disease or ischemia. And we felt that at the age of 50, with chronic hypertension as a cardiovascular risk, as well as systemic inflammatory disease, which we know that these patients may have accelerated atherosclerosis, at least some of them, we felt it would be reasonable to start with an emergency coronary angiogram to rule out the possibility of acute coronary syndrome. But I must say that the team discussion was not straightforward, and it was mainly based on the echocardiography team reviewing the echo and saying that they were under the impression that it was not global dysfunction of the left ventricle, but more inferior than other segments. Mm-hmm. And I can also, there are several other options here that we were also discussing, William. We were discussing the option of taking the patient to a CT, maybe a triple rule-out CT to rule out coronary disease, option of PE, and also to review the extent of lung injury due to the virus. And the other two options that are less, I would say, very low in the diagnosis workup were cardiac MRI, which is not readily available for us during the night. That was in the night the case. And also some argued that endomyocardial biopsy would be reasonable in order to guide treatment, as we know that some patients have a viral damage while others have a more of an immunosuppressive, aggressive response that damages the heart.
Thank you. What strikes me, though, is that let's assume this is COVID myocarditis. This would be the main symptom of the infection, because otherwise, patient has no fever, has no cough, has none of the symptoms, and also we don't have CT of the lungs, but at least the chest X-ray does not really suggest that there is massive pulmonary COVID infection at this moment or inflammation. So there is one other option here on the slide, because thrombolysis has been proposed as a first-line treatment option in patients with acute MI, for instance. in this particular case? And in general, Flavio, is this something you would have recommended or considered?
Well, William, thrombolysis is a very effective therapy when there is no option in patients with ST elevation. So if this is the rule in your background, because in your country you use thrombolysis, this is, of course, could be considered. This is not the case in our country. Probably it's not the case in Tel Aviv. We don't use thrombolysis anymore. And I think there is absolutely no reason to change our manner of managing these patients just because they are COVID positive. We know PCI is better than thrombolysis, and I think it is even better in patients like this, because if the suspicion is that of perimyocarditis, performing a thrombolysis would worsen the clinical situation with no benefit. If you do a coronary angiogram, will be useless, but you will have a certainty that there is not ischemic impairment in this. This is not an occluded right coronary artery. In between the option of CT scan and angiography, of course, CT will give you important information regarding the lungs, which is, as you said, surprising that she has normal oxygen saturation, it's not a pulmonary damage, it's a cardiac damage. But in case you find an occluded coronary artery, which is not so straightforward in a patient with tachycardia, then you will have to go to the cath lab to open the artery. So I would skip this way. It might be sensitive to perform an MRI, because an edema in T2 will put you a very straightforward on the suspicious of massive myocarditis. But of course, if this is not available in the night, or it's not available worldwide, it's a quite high level and complex examination. If the discussion is in between thrombolysis, CT, and angio, I'd go for an angio.
Thank you. I guess a consideration also for thrombolysis is if you have only one cath lab, okay, and you want to try by all means to, have COVID plus patients in the cath lab, in your single cath lab, if it isn't absolutely necessary. So I guess that could be a consideration. But in this particular case, not being certain, even 100% certain that there is a coronary abnormality, for sure you wouldn't consider thrombolysis at all in any instance. And if you have a good coronary CT, yeah, perhaps that's a good option from that perspective, preventing your cath lab from being infected, quote unquote. Right. Do we have anything to add at this point? Maybe we can move on. And Elad, would you like to tell us what was your decision with the team? And please lead us through the further diagnosis and treatment and outcome of this patient.
Sure. Thank you, William. So our team decision was to proceed with an emergency coronary angiogram and to treat a COVID patient like we treat any other cardiovascular patient. Here you can see the setup. The COVID unit was in a separate building within the Sheba Medical Center complex. You can see the ambulance. You can see the team that is very well protected. Transfer team, the patient is in a separated environment that is well separated from the transfer team. Everyone are protected completely. And the patient was actually very much stable. She was in good spirit. She had no chest pain. And in a matter of fact, she didn't really understand what we want from her. You can see here the setup of the room. So we closed the air conditioning system so that we will not have a positive pressure in the room that will reduce the chances of infecting the environment. We have 5 catheter rooms, and one of them is currently a dedicated room for COVID patients. The control is also separated. We use the 5 French approach because I was under the impression that it will probably be a normal coronary, and that's what it was. Since the patient went directly back to the internal medicine COVID unit, we used 5 French in order to reduce the chances of complications, radial complications, because they are less comfortable with managing TR radial stop. So she had completely normal coronaries. She felt well. Saturation was normal. She was laying flat in the catheter room with no problem. I was well protected with double gloves. I was with an N95 mask. The patient was also with a mask. And I also had a face protection. But unfortunately, during the next 24 hours, her condition deteriorated. She was hemodynamically unstable. You can see the next day echocardiography showing globally and markedly decreased left ventricular ejection fraction. You can appreciate that the right ventricle is not dilated, and you can see pericardial effusion supporting the diagnosis of perimyocarditis in a patient with normal coronaries. And here you can see the hospital course. Unfortunately, the patient dies at day 9, but you can see that on day 0, she was admitted at 4 in the afternoon with dizziness, hypertension, and STEMI. The angiogram was performed within 5 hours at the same evening at 9 p.m. The next day, she had normal chest X-ray, no chest pain. She was treated with fluids and inotropes. Our infectious disease team recommended her to be treated with antibiotics and Plaquenil. But despite the treatment, she was hemodynamically unstable. As I showed you in the echo, she had severe left ventricular dysfunction. And midnight, between day 1 and day 2, the team decision was to intubate her and connect her to an ECMO, mainly due to the fact that she was very much unstable hemodynamically on inotropes and fluids. We then started treating her with intravenous immunoglobulins and corticosteroids. She continued with the treatment with Plaquenil and antibiotics. Unfortunately, her situation continued to deteriorate. On day 6, her chest X-ray finally shows a severe ARDS and white lungs, acute respiratory distress syndrome, like picture. And on day 7, she develops disseminated intravascular coagulation, DIC, and multi-organ failure. And here you can see her day 6 chest X-ray that shows you a picture of very severe lung injury with bilateral white lungs. Very different, William and Flavio, from the previous chest X-ray. And here you can see laboratory data. As I discussed with you, she started with very much elevated troponin that remained elevated throughout her hospital stay. But interestingly, despite fulminant myocarditis, her CRP at her admission was borderline normal. Our reference values are 5. And her D-dimer was also borderline normal at 479. You can see that during her hospital stay, CRP levels increased significantly. And in the last 2 or 3 days, when she was with disseminated intravascular coagulation, her D-dimer levels went very high.
Thank you. Thank you very much, Elad, for describing with great detail the diagnostic thinking and the further treatment. So I'd like to invite all of you attending this discussion to share your views, opinions, and questions, and we'll take them as you submit them through this little red box on your screen. And again, feel free to do it anonymously or to indicate your name as you prefer. So while the questions are coming in, I will filter them and address them to either of you. In the meanwhile, we have this diagnosis now of acute pericarditis and myocarditis. I assume that is due to the COVID-19. What is known about this disease at this stage? Have you looked into literature or references? And I'm asking to each of you, what is your view on this?
So I had the opportunity to review the literature in preparation for this discussion, and I think that the contemporary view is that there is a viral phase and an immunological phase for this disease. During the viral phase, it's probably the virus that is causing the damage, but later on, it's more the immune response that has a dramatic and devastating implications for the patient. And I think that it's not clear for me what was more relevant in this case. Was it the virus or the immune response? I must say that the fact that the patient was immunosuppressed and had makes me feel that it's probably more likely that it was the virus itself that contributed to such a fulminant course.
Yeah, I think you also mentioned while we were preparing the case discussion for this presentation that you had, this person was under regular control, and you have a relatively recent echocardiogram that showed normal LV, right?
Yes, in March, she was from a very good, she was under a very well medical follow-up due to her scleroderma, and she was very much, we had all the medical records of her previous visits, and she, on March 2019, which is less than a year since from her hospitalization, she had a formal echocardiography workup, and that demonstrated a normal left ventricular ejection fraction, no evidence of pulmonary hypertension, and no evidence of valvular disease.
And Flavio, is there anything regarding known regarding the treatment of these viral fulminant variant myocarditis? Is there anything known about it?
Well, the myocardial involvement that has been described in symptomatic patients is not infrequent, but it's not the driving part of the disease. It's present in between 10 to 20% of COVID positive patients. But of course, this can be just detected by a rise in the troponin levels, but there is no hemodynamic impairment. Hemodynamic impairment with oxygen, which goes beyond the expected, secondary to the oxygen desaturation related to pulmonary problem, happens in less than 2 or 3% of patients. This is not our experience. We have not seen in Verona myocardial involvements, but this is what I have seen and what I have talked to other colleagues. You know, we have a very big expert in myocarditis in Italy, who is Gianfranco Sinagra, who is following this. And we had a talk on this purpose. And of course, the first part of the disease is very related to the cytokines release. This is a very acute phase of the first part of the inflammation is linked to the high levels of cytokines, and it's a very highly prothrombotic situation, mainly targeting the lungs. But probably in this patient, for reasons we don't know, I personally am not an expert in this, the target organ was the heart. And since the beginning, it was the hemodynamic impairment, the pericardial effusion, the ACG. Now, after we know the diagnosis, it's clear that it's a case of fulminant myocarditis. The hemodynamic support was provided very early, so I think that the management was, because in day 2, she was intubated and in ECMO. You cannot do more than that, except the medical therapy. At that point, if you have the certainty, the clinical certainty of the myocarditis, and she is not responding to the conventional medical therapy, so at that point, there might be room for a myocardial biopsy, which will likely show a huge edema and massive infiltration of lymphocytes and acute inflammation that would guide you to a more aggressive therapy. We, of course, don't know anything about which might be the outcome of this more aggressive empiric therapy, but it's the only different things that you might have done in your case.
Thank you. So we're receiving lots of questions here. I'm going to turn them to you, and let's try to address them briefly. There is a question about anticoagulation, but I suppose, Elad, that in the context of ECMO, that is ex officio, and even without ECMO, I suppose patients intubated and in the intensive care like this would be anticoagulated anyhow. Do you remember about that?
Yes, so yes, William, I think this is a very important question. We know that there are several publications circulating right now about the need for anticoagulation in COVID patients. But as you said, in this specific case, she was on ECMO, and therefore she was fully heparinized throughout the case. And you have to remember that this comes with a price of the risk of bleeding complications. She did have some issues with bleeding from the access site that were managed locally with success. But I must say that anticoagulation to patients that are not on ECMO should be carefully considered with respect to the risk of complications.
There is a question on the use of Plaquenil, because I think it is in the list that this medication was given to the patient. So is this standard in your place, Elad? And I'll ask Flavio as well. Elad?
So at our institution, I think this question reminds us, it's a humbling question because it reminds us that we are the cardiologists and this disease is not a cardiovascular disease. So we have a team of excellent infectious disease team that are taking care of the decisions about Plaquenil. And it is my understanding that most patients at our institution that are inpatients, they receive Plaquenil. Yes, William.
Yeah. Is it routine also in Verona, Flavio?
Yes, hydroxychloroquine is part of the therapy. There are many other retroviral drugs that are being tested. And since Italy, unfortunately, has been strongly hit by this disease, there are several randomized and controlled trials that different hospitals and the Ministry of Health have approved very quickly, running in the University of Padova and Verona and Rome. Padova and Verona have been very strongly involved in this pandemic. And I guess we might have some initial results at least in a month or a month and a half.
Yeah, you may know that, in France, there is a huge controversy about the use of these drugs because, there is interesting data, but no formal trial. But many countries have taken the position that, if we don't have anything else better, pending QT monitoring, perhaps we should give it. Let's try to address more questions, many coming in. So I'd ask both of you to try to answer them in few words. Interesting question here to me. Why did the patient not have chest pain? Any hypothesis?
Okay.
I guess the answer is we don't know. Yeah.
Of course, we don't know. Elad said that the lady was, before this event, was quite a healthy person with a positive personality, probably not the type of complaining lady. But it's true that she didn't have myocardial infarction. So there was this clinical part was missing. She never had angina. So this goes against the suspicions of myocardial infarction. Normally, myocarditis might have atypical chest pain. And in the case of pericarditis, this is a typical. She had a circumferential pericardial effusion, but she didn't feel pain. Why she didn't complain, we will never know. But what we know, which is a clinical relevant point of view, is that she never felt angina. So, and this goes against the ischemic etiology.
Yeah. Still questions, several ones actually. Take one here from Arturo Jacaman from Chile. Thank you for joining. And the questions are about, what is what? And particularly, this person was immunosuppressed because of her scleroderma. So the hypothesis is it possible that this COVID infection has created a cytokine storm that was perhaps also the combination of the scleroderma and the COVID? Could it be that the COVID created an exacerbation of her underlying comorbidity? Hypothesis, but I don't know if you have any idea about that.
I think that the infectious diseases team at our institution, from the very first moment, felt that it would be reasonable for her to be admitted and not to stay in home isolation, only due to the fact that she was on methotrexate. And I think this is a very good question. I don't think we have an answer, William, but I agree with the question, and I feel that either direct viral damage or unopposed cytokine storm were most likely the explanation, the most reasonable explanation for this very malignant course. I must say that we see several cases like this a year, even without the COVID. So I guess that this is something that is very uncommon, but in large centers, you might see one or two or several cases like this every year. Wouldn't you agree, Flavio? Do you see cases like this, even not at the time of the COVID, right?
Yes, of course. Aggressive myocarditis is one of the reasons why we became in Veneto one of the hub centers for hemodynamic support with ECMO. We have every year young people with fulminant myocarditis having 10% ejection fraction, but they recover, most of them, after 1 week of ECMO and ventilation after this acute storm and under aggressive steroid therapy. They recover. You can win these patients. Maybe you need to vent these patients. That means to associate ECMO and a venting therapy to reduce the LV pressure with an impeller, for instance. But we have had excellent results in these very young patients. This might be a much more aggressive virus. It's a kind of myocarditis. We don't know. As William said, the association with chronic inflammatory disease in an immunosuppressed patient might have created this disaster.
Thank you. A couple more questions that bring us back, take us away a bit from the, infectious disease or the immunology of the myocarditis and bring us back to the cardiovascular care. There is a question about, is it usual for the general intensive care to deal with patients under ECMO? Or is this a decision that was taken because this is a COVID plus person? Elad?
So yes, thank you, William. At our center, at the Sheba Medical Center in Tel Aviv, in Israel, the cardiovascular intensive care unit takes care of ECMO patients. We have a heart hospital, basically. It's a heart center with cardiovascular surgery and cardiovascular intensive care and echocardiography and everything is in a single building, including vascular surgery. And ECMO patients usually stay at this hospital and not in a general internal medicine or surgical intensive care. This case was very special in the fact that was the first time that the intensive care, which was comprised of intensivist and internal medicine physicians, was taking care of an ECMO patient. And it was a challenge. There were some difficulties with access and with some bleeding from the access site that will need to be taken care of by a team that is not used to taking care of ECMO patients. These patients, also the question of when to intensify or de-escalate the ECMO, these are things that the team was not very much used to, but our excellent cardiovascular surgery team and anesthesiologists, CV anesthesiologists, supported them. And I feel that this patient received an excellent ECMO, despite the fact that she didn't survive.
Thank you. And in Verona, Flavio, who's taking care? I guess it's a team, but where would this patient, COVID plus with an ECMO, where would they be treated? In your intensive care, coronary care, or in the general intensive care unit?
Well, the implantation of the ECMO happens 90% of the times in the cath lab or in the operating rooms when it's a surgical patient. But for a case like this, performing an emergency coronary angiogram, at the point she did the angiogram, she didn't need the ECMO because she was doing fairly well. But in our center, the ECMO would be implanted percutaneously by our team of interventional cardiologists. But then the managing of the patient is taken by the specific cardiovascular intensivist, which belongs to the cardiovascular surgery division. This is a specific case of a COVID positive. So we have divided intensive care units in COVID positive and COVID negative. She would drop into the COVID positive, where very likely you will not have one of the anesthesiologists of the cardiovascular division. But in this case, what we do is consultancies. We dress appropriately, we go to the patients, and then we undress when you get out. This is, we haven't had a patient, fortunately, a COVID positive patient under ECMO so far, but this is what we would do in Verona.
Couple more questions, thank you. Yeah, one person is asking whether she had an angiogram, so we can just repeat that. Yes, she had an angiogram that showed nice coronary arteries without stenosis. There is an interesting question here that pertains to an ongoing what should I say, controversy, and the question is: can you attribute her use of ACE inhibitors to her deterioration? She was treated with ACE inhibitors, I think, for chronic hypertension. And is it your experience, or what do you know about the positive or negative interaction between the use of ACE and outcomes in COVID-19 infections? Would like to take that one? Controversial issue.
There is no clear evidence. There is no clear evidence. It's an observation. There is a background related to the bradykinin increments in ACE inhibited patients. So there is I'd say, quite weak rationale. But of course, I wouldn't say more than that. What we have seen is that hypertension, it's a very frequently related risk factors in those patients that had, because we have to say something, it's not that every COVID patient dies. I mean, the mortality is higher than a seasonal flu. But it's not that every COVID patient should be recovered in an intensive care unit. One of the most important messages that doctors have to know worldwide is that the best thing that you can do is keep these patients at home, isolated with a telephone to call the emergency service in case they feel very sick or they have important shortness of breath. But putting patients in the hospital when they don't need it means that you will contribute to the expansion of the infection and contagions of patients and medical personnel and nurses. But apart from that, it has been shown, it has been observed that most patients having, let's say, a complication during the treatment for the respiratory part of the management are very often hypertensive patients. There is a link in between these risk factors more than what you expect being diabetic or maybe hypercholesterolemic, but hypertension has been shown to be associated with a poorer outcome.
Thank you. A few more questions, and then I think we will perhaps summarize and wrap it up. There is a question, very short answer, please. Is there any experience with the use of tocilizumab in COVID-19 plus patients? Is that one of the ongoing trials, particularly with myocarditis, that you're aware of? I see you're nodding yes, Flavio.
I want to make clear, I mean, the cardiologist is not the one leading the medical therapy. Cardiologists are useful in doing the angiogram, supporting the hemodynamics and reading the ACG, but the medical therapy is decided and followed by the infective specialist, the specialist in infective disease, together with the intensive care. But it's not the cardiologist. I have heard from my colleagues that this is one of the drugs that is being used, and it's also tested in a study.
Another question, but you mentioned it, Flavio, that sometimes there is a need for other LV assist devices. You mentioned Impella or even balloon pump when you need to associate unloading, I suppose, with the ECMO treatment. Makes it a very aggressive and invasive treatment, but that's what's needed. So at some point in time, you need to keep the peripheral output by using Impella or balloon pump in those patients with ECMO.
This is not. William, this is not related to COVID patients. This is related to any patient in mechanical circulation, circulatory support. Yes. This happens. I mean, the more you use it, the more you understand that this is needed. Venting was, until 2 or 3 years ago, was a surgical approach. A lot of complications, a lot of problems. Now with the availability of a coaxial pump to do the venting, of course, this is much less invasive and effective. And because the venting might be needed only for 2 or 3 days until you have the recovered of the LV function. And so it's an excellent association.
So how many of your patients actually need ECMO in your experience, Flavio, and you, Elad, since you've started treating those patients? I mean, this is a minority, or because I don't think we should give the impression that to treat a patient with cardiac disorders and COVID, we need to have ECMO in all patients, right? It's a minority of patients who need it. Correct?
A very small minority, I would say, and I'm not 100% updated, but to the best of my knowledge, that was the only ECMO case of a COVID patient in our institution since the COVID pandemic started here. We have 10,000 cases already in Israel, and our hospital has more than 100 patients, and I think that was the only one that was connected to ECMO. Flavio?
Well, the figures are much bigger in our region. I don't want to give this misleading message. I mean, myocarditis is an infrequent presentation and complication of the COVID. It will be much more frequent that we will be called to open an occluded artery in a COVID positive patient. Your case, it's extraordinary because I think it's one of the very few. And this is not our aim to say, be ready with your ECMO device because of the COVID pandemic. I mean, this is absolutely extraordinary. This is a patient that goes into the extreme of the spectrum in which the damage was the myocardium and not the lungs, which is the much more common. And then, as I said, as an interventional cardiologist, we will be called to open an occluded artery with a PCI in a COVID patient, and very unlikely to put an ECMO. But of course, in a high center like yours, this might happen.
Flavio, short answer, please. And say hello to Dr. Joël Keffer from Brussels. In your experience, what is the survival rate of a COVID plus patient under ECMO?
If I might say, this is the only case I've heard of a COVID under ECMO.
Under ECMO, because of the myocarditis. Yes, okay.
We have patients of venous ECMO for the pulmonary problem, but this is totally a different thing. It's not because of the myocarditis. Pulmonary.
But the question was generic. The question was generic. Out of all patients that need, not only the ventilation and lung support, etc., among those who eventually need COVID, even for oxygenation, how many needed ECMO? How many will survive? That's the question.
Well, for venous, we had a couple of good results. For myocarditis, as I said, we had none.
Good. Very nice comment from Dr. Robertas from Lithuania. Thank you very much. He wants to thank you for discussing and presenting this case. So I'm transferring his nice words to you. He has an interesting question at the end for Elad. Is there anything you would have done different in retrospect?
This is unfortunately, I must say that the answer is no. I think that we were very proactive and aggressive. She was asymptomatic, went to the cath lab as an asymptomatic patient. She was connected to the ECMO in less than 36 hours from admission, with basically being hemodynamically unstable, but one might argue that we could have waited an additional day or two. So I think that we were very proactive, and she was treated by the top team of our hospital. And I must say that I can't think of anything that we could have done different. Waiting and pending for the results of the clinical trials, William. We have to wait for the clinical trials.
Thank you. So I propose that maybe, after discussing in detail many aspects of this, complex and somewhat unusual case, perhaps, but maybe it's time to reflect on what would be the key learnings. And I think you've summarized this in a slide here. So this is your final diagnosis: fulminant myocarditis mimicking inferior STEMI. And I have to say myself, I would have gone straight into the inferior STEMI hypothesis, but okay, I was proven wrong. So I'll start with you, Elad. Out of these key learning points, which are the ones that you would really like our colleagues who are watching the video here to take home?
I think there is more and more understanding that we should treat COVID STEMI patients or COVID cardiovascular patients the same way that we are treating any other patient. I feel that not taking a patient with this ECG and hypertension to the cath lab just because of concerns to the safety of the cath lab or the team or other patients wouldn't be the right pathway. And I feel that we have to remember that we as cardiologists have to give the optimal cardiovascular care to our patients. So I would go with key learning point 2, treat STEMI COVID patient like any other patient.
Thank you, Flavio. Which is the key learning point that you would like to emphasize at this stage?
First of all, I agree what Elad said, and goes together with not doing thrombolysis if you can perform angiogram instead, which goes together, in my opinion. But my main message would be try to work in a team and do your best as a cardiologist, although remember that in this COVID problem, the cardiologist is not a team leader. It's not a regular myocardial infarction. I mean, the team leader is the intensive care and the colleague specialist in infective disease. You contribute, but they are taking the main decisions, especially in the therapeutic field.
Elad, another point?
I think that the only point I am struggling with, and I hope that maybe this will open a fruitful discussion, William, is what is the role of endomyocardial biopsy? These patients are unstable, but I feel that we need to understand and to guide therapy, because if the PCR of the virus is positive within the heart, it's one problem, but if it's only inflammatory response of the heart, that's a little bit different. And I feel that the question of will endomyocardial biopsy help us to guide therapy, specifically the use of pulse corticosteroid therapy and immunosuppressive therapy, I think this is an open question. And that's the only question I'm struggling with. Should we do biopsy for patients with COVID who present with a globally reduced left ventricular ejection fraction?
And strong evidence for very aggressive myocardial damage, as if you remember, the troponin values kept increasing over time, day after day. Yeah. So there was strong evidence that the myocardium was actually being progressively destroyed in this particular case. A final comment regarding key learning point, essential message that you would like to share with the colleagues based on your experience in Italy. Flavio, strong statement. Final.
I stay on simple recommendations. Keep your cath lab and your cardio division clean. Use the personal protection devices appropriately. Establish a clear pathway for COVID positive patients from the emergency room to the cath lab to the intensive care. Don't take positive patients into the intensive care unit in the cardiology, because then the game is over. And so this is, again, the importance of working in team. I mean, we can help, but we are not the leaders.
Thank you very much. With these very strong key learning messages at hand, I'd like to conclude this first PCR on call interactive live case discussion. And of course, I want to thank Elad very much and your team for sharing this case with us. I want to thank Flavio for sharing his experience and discussing all aspects of the care of this patient. I also want to thank our broadcasting and support team, all the people behind the scene who have helped us to deliver this first interactive case discussion. We will have more of those to share with you on a regular basis. Different patient cases from which we will learn how the COVID disease, like in this case, or the COVID environment is complicating our task, which is to take care of patients with cardiovascular disease and help in those patients who have a global problem to fix their hearts. So stay tuned. I want to thank all of you who have taken part in this video, and particularly those of you who have shared and posted their comments or questions. So stay tuned, keep safe, and thank you all for joining.